Yeah, live.
Now the time. Oh, are we live? Okay, ma'am. Over to you.
You'll introduce?
We are live.
Okay. So good evening, everyone, and I welcome you all for this MOS PG webinar. And today we have two cases. As you all know, this month we are presenting cases on uveitis. So today, Dr. Avni Kabra and Dr. Athira, they will be presenting cases. Dr. Avni Kabra, she'll be presenting a case of pan-uveitis, and her mentor is Dr. Pradnya Deshmukh, and Dr. Avni is a second-year resident, and she's from MGM Medical College, Chhatrapati Sambhajinagar. So I request, and today's panelists, they are Dr. Nikhil Beke and Dr. Soumyava Basu. So we are honored to have both of them for this for their expertise in uveitis. So over to Avni. Dr. Piyush, you want to say something?
So we have an exciting webinar, and many thanks to our esteemed faculty, especially Dr. Soumya Basu, who's the LVP and Network Director of the Department of Uveitis, with the tremendous amount of work on tuberculosis. Probably there is nobody else, very few people probably around the world who can match the work that he has done on uveitis, especially presumed ocular tuberculosis. And we have Dr. Nikhil Beke. He's my dear colleague practicing in Pune. He is a consultant at Dinanath Mangeshkar Hospital and trained at PGI Chandigarh. So with this, let us now start the presentations.
So Dr. Avni, will you please share your screen and start presenting your case?
Yes. Oh, is my screen visible now?
Yeah. But you need to make it slideshow. Yeah.
Good evening, everybody. My name is Dr. Avni Kabra. I'm a second-year resident at MGM Medical College. I'll be presenting a case of a 15-year-old female admitted in pediatrics ward who was referred to ophthalmology with the chief complaints of diminution of vision in both eyes since the past 15 days. The patient was apparently all right 15 days back when she started experiencing a decrease of vision in both eyes, which was sudden and painless in nature. The vision deteriorated further over the course of 15 days. It was preceded 1 week before by high-grade fever, projectile vomiting, severe headache, and there was history of redness in both eyes since the past 15 days. There was no history of watering, no history of pain, no history of photophobia, no history of floaters, no history of flashes of light, no history of ocular surgery, no history of joint pain, and no other significant history was noted. Patient had shown in a private hospital where she was advised oral antivirals and anti-inflammatory medications and topical eye drop prednisolone 4 times per day, after which she was referred to our hospital. There was no history of ocular trauma, no history of any similar episode in the past, no history of any systemic illness or any systemic medications. The personal history and family history were not significant. On general examination, she was febrile. All other vitals were normal. On systemic examination, all the systems were normal. On visual acuity testing, the uncorrected visual acuity of the right eye was finger counting close to face. The projection of light and perception of rays were accurate. It was not improving on pinhole. On left eye, the uncorrected visual acuity was finger counting 2 meters, which was not improving on pinhole. An ocular examination, the head posture was normal, the facial symmetry was maintained, ocular movements were full and free. On visual axis, on HBT, the patient was orthotropic, and on cover-uncover test, no deviation was seen. On torchlight examination, the pupil were 4 mm in size, normal in shape, and sluggishly reacting to light. Rest of the anterior segments I will describe with the slit lamp examination findings. The IOP on applanation tonometry was 22 in the right eye and 20 in the left. On the right eye, in slit lamp examination, the eyelids were normal. The conjunctiva showed mild circumcorneal congestion. On the cornea, there was fine, fresh keratic precipitates diffusely spread over the corneal endothelium. On the anterior chamber, there were cells and flare present. The iris showed normal color and pattern. The pupils were fully dilated when I under the effect of mydriasis, and the lens was clear. There were a few iris pigments on the anterior capsule of lens. In the left eye, similarly, the eyelids were normal. The conjunctiva showed circumcorneal congestion. The cornea showed fine, fresh keratic precipitates spread over the corneal endothelium. The anterior chamber showed cells in flare. The iris showed normal color and pattern. The pupil was fully dilated and the lens was clear. In the right eye, on fundus examination, there was grade 2 to 3 vitritis seen. The disc was seen hazily. The disc appeared pale in color. There were multiple whitish lesions spread in the periphery and mid-periphery, suggestive of retinitis. There were multiple superficial hemorrhages. There was sheathing of arterioles and venules seen. And the macula, there was a whitish lesion of around 1.5 disc diameter overlying the macula with the overlying hemorrhage. In the left eye, there was a lesser grade of vitritis, almost grade 2 vitritis was seen. The disc appeared pale in this eye as well. There was sheathing of vessels. There were multiple whitish patches in the mid-periphery and periphery. The macula in the left eye appeared slightly edematous, and there were multiple superficial hemorrhages seen. The systemic investigations done for the patient showed a normal hemoglobin. The TLC was slightly raised. The liver function test and renal function test were normal. The serology was negative. The urine routine was normal. The CSF was clear in appearance with 18 cells per cubic millimeter and increased lymphocyte count, suggestive of a viral etiology. The adenosine deaminase was less than 1, which suggests that it was a non-tuberculous etiology. Radiological investigation showed a chest X-ray which was normal and MRI brain findings which was suggestive of viral encephalitis or acute disseminated encephalitis. My provisional diagnosis was both eye panuveitis, and on differential diagnosis, the most probable differential diagnosis for this case were herpetic retinitis for ARN or PORN presentation, CMV retinitis, syphilis, toxoplasma or tubercular, and non-infective were VKH and Behçet's. The treatment which we had started the patient on was injection methylprednisolone 1 gram for 3 days, injection acyclovir TDS, and in both eyes topical steroids, topical homatropine, and topical iotam. BD. The patient had unfortunately was non-affording and she had gone home, but I had spoken to her afterwards, and she said she had continued the same treatment. In the right eye, her vision currently was 636, and in the left eye it was 618. But she did not come for follow-up, so we do not have any follow-up pictures for her.
Very good presentation, Dr. Avni. And I would like to request Dr. Basu to ask her questions. So this is basically a PG case presentation, and we discuss the likely questions that would be asked in the exams. So I would request Dr. Basu to ask questions to Dr. Avni. So you are mute, sir.
Yeah. So I think this was good documentation of the case. There are two things where it kind of struck me, which could have been done differently. One is the negative history that you presented. Okay, so while it is a tradition to present all the history at one go and then present all the investigations at one go, but if I were the examiner, I would have gone with the initial set of history. How did the disease start? And then examine the patient and then revisit the history depending on what you find in the picture. Okay. There are minor things, that slide on negative history was very instructive. Some of the things that you could consider not going into. For example, history of joint pain. It's a reflex action by which we ask history of joint pain in any ocular inflammation. First of all, this kind of an inflammation that you saw, joint pain is probably irrelevant.
Yes.
The other issue is that even if you see some kind of inflammation, for example, a hypopyon uveitis or a non-granulomatous anteuveitis, you do not ask for joint pain alone. You ask for an inflammatory back pain or an inflammatory joint pain, which is more in the morning and disappears in the evening. That way it makes sense. The other part was your, the fundus findings. Okay. So fundus findings, the posterior pole definitely was giving the hint that there could be large areas of retinitis in the periphery. Okay. So that should have been described in detail. It's okay if you are not able to take a photo of the peripheral fundus. Okay. Sometimes the camera doesn't reach there. Sometimes the vitritis is there, which is why the peripheral fundus is not visible. But to take your case to the next level, it would have been very good if you would have drawn it on a piece of paper, drawn a fundus diagram and showed, see, this is the area where I saw retinitis. Okay.
Yes.
Since I'm supposed to ask you questions, let's try to do that. I have not been an examiner for a very long time, so not in that habit very much, but I'll try my best. So what would be your morphological diagnosis for this patient?
So it looks to be retinitis, more of a
So
retinitis.
I revise my question. Let's start by what is the anatomical diagnosis, what is the morphological diagnosis, and what is the etiological diagnosis. Three things. And remember, etiology doesn't always need blood tests. Okay, you can tell etiological diagnosis by the morphology as well. Yeah.
Anatomically, it most probably looks like a retinitis.
So where do
Primarily
where do we derive our anatomical diagnosis from? Which paper or
Sun's class.
Sun classification?
Yeah.
So do you have Sun classification? Do you have retinitis as an anatomical diagnosis?
So posterior uveitis, which is
posterior uveitis, right? So even though this patient had significant amount of anterior segment inflammation, but the focus of inflammation was in the retina.
Yes.
Okay. So it would not be probably correct to call it panuveitis. You would rather call it a posterior uveitis. That's the anatomical diagnosis. How about the morphological diagnosis?
Morphologically.
You mentioned that earlier, morphological diagnosis. You just mentioned it before this when I asked the question. Retinitis. Can you add some prefixes? So the better you are in uveitis practice, the better you are in adding prefixes to your diagnosis. So add some prefixes to retinitis.
So it is most probably a case of both acute retinitis following probably a viral etiology.
Yeah. So, if I would, though I have not seen the periphery, but guessing on what you might have seen, I would call it a diffuse retinitis. It's not a focal, right? There was diffuse patches of retinitis. Yes. So diffuse retinitis, which is peripheral. Okay, diffuse peripheral retinitis associated with diffuse perivascular sheathing. And if you look at the vessels, there are more of arteriolar involvement than the venous involvement. That is what will happen in acute retinal necrosis. Yes. And possibly vascular occlusion as well. And remember that similar vascular occlusion happens to the optic disc as well, which is why the disc goes pale. In fact, the most common cause of loss of vision in acute retinal necrosis is optic atrophy. Okay? So, diffuse peripheral retinitis with periarteriolitis, giving the appearance of acute retinal necrosis. Now, acute retinal necrosis in this case is both a morphological diagnosis as well as an etiological diagnosis. Yes. Now, when you say acute retinal necrosis, it doesn't necessarily mean that it is caused by HSV or VZV, any of the two viruses. Rarely in HIV positive patients, toxoplasma can also cause a picture like that. Okay? So, acute retinal necrosis in this case is both etiological as well as a morphological diagnosis. Okay. Now, what are the complications of acute retinal necrosis?
So, it primarily leads to disc pallor, which will cause a diminution of vision. There are multiple necrotic lesions which can be seen in the retina, which can cause not vision will not be recovered if there are
Yeah,
confluent
but it
necrosis.
doesn't involve the macula, right? Usually doesn't reach up to
It
the
doesn't
macula.
involve.
So what other complications will it cause? Acute retinal necrosis?
So it might cause I'm
Okay.
not sure.
Some people do laser for that, which is not correct though.
Ischemic.
No. Anyone else? Can I ask anyone else, or only she has to
Yes,
answer?
you can ask.
Okay,
Athira,
so, yeah.
Athira, can you unmute? Did you understand sir's question?
So could you just
The
frame it
complications
once
of acute retinal necrosis. I think this is pretty much a PG question. One was optic atrophy, which is absolutely correct. The other is okay. So the other is rhegmatogenous retinal detachment. Okay, because these peripheral necrosis will lead to small sieve-like breaks in the retina, which causes rhegmatogenous detachment. Okay. In the earlier days, people would advocate doing laser barrage around the retinitis lesion, but that really doesn't help very much. Sometimes, if the area of retinitis is very large, then it can also cause exudative retinal detachment. Okay. Now, how do you go about? So now you have made the diagnosis of acute retinal necrosis. You are aware of the complications. Now, what will be your next steps? You don't have to do a Montu test in this patient or a Toxo test in this patient, right? Because that is not relevant. So, what would be your next steps?
So we can do a PCR for
Acute retinal necrosis, I think that's a misconception. It doesn't need a PCR for it's a purely morphological diagnosis. But what other blood tests would you want to do in this patient? Actually, you have done those tests, but I still want to hear it from you.
routine hemograms, or we can
No.
fish.
No,
And
you should have a clear reason why you want to do which test. You have done those.
LFTs should be done for if the LFTs are raised, we for antivirals, considering which
Yeah,
antivirals.
more than LFT. LFT is also important, but more than that. What do the antivirals affect more than the liver? Which other organ?
Kid.
I don't know if examiners give so many hints in the exam. Okay. So you want to do the serum creatinine, and it's still better. You would want to know the eGFR values. Okay. What other test which you have done, which is very important in this patient?
So serology should be done because
so you want to know if the patient is immune
patients
competent or
or
immunosuppressed.
immunocompromised.
Okay.
Yes.
Immunocompromised. You would definitely, since it's a retinitis lesion, you 100% need to do a syphilis serology. So you want to do a TPHA.
Okay.
We have had enough patients who are both acute retinal necrosis plus syphilis, especially HIV patients. Okay, so you would want to do a TPHA for sure. Okay. Do not do a Montu test in this patient because you will unnecessarily get mixed up. Montu might turn out to be positive and it has no relevance in this patient. So a TPHA, HIV, and blood counts and the renal function test are extremely important. Okay. Now, how do you go about the treatment? What are the treatment protocols for? What are the drugs that are available and how can you administer those drugs?
So antivirals we usually give.
Which antiviral?
Acyclovir is usually used for HSV and
What is the dose of acyclovir?
So 400 mg BD per day.
Of what? IV or
So for
oral?
oral, for
Oral
IV,
400 BD for acute renal necrosis.
so it's 800 mg/BD for
BD. This is, a make or break answer. Okay, not done. All right, read it up.
five
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 times a
times
day.
per day. Sorry,
800
times.
milligrams
Yes.
5 times a day, or
And injectable.
valacyclovir. Yes, you can inject ganciclovir, but ganciclovir usually does not have a very strong effect on HSV or VZV. We do inject. I also advise injections, but don't expect it to do any magic. Your main drug is acyclovir or valacyclovir. Do I have more time, ma'am, or I am exceeding my time? Then I'll stop here.
No. You are in time because we
Okay.
have to finish this case by 8:30. But I
Okay.
was wondering with
Nikhil would want to ask some
if
questions
Dr. Nikhil
probably.
is there.
Yeah.
Nikhil, would you like
Nikhil,
to
you can
ask
take over the
any
treatment part.
questions?
Yeah, so basically, I just wanted to highlight Dr. Basu's point again that we have to differentiate a simultaneous involvement of multiple uveal parts versus a spillover inflammation going from one element, one part of the uveal tract to other. So this is not really a case of panuveitis. And how often, in my experience, and I mean, how often do you expect to see this acute retinal entity being bilateral? My question is, how often or how common is it to have acute retinal necrosis bilateral, simultaneous presence?
It's mostly unilateral in presentation.
My other question is, I think Dr. Basu was leading to it, is after starting the antivirals, where exactly do you introduce steroids in this case? Because as I read, you started with acyclovir as well as methylprednisolone simultaneously. So where
So she
exactly
was
do you bring in the
started
steroids?
on antivirals outside. She was started on antivirals previously.
I think I think there's a mix-up because the patient was initially managed elsewhere and then came to you.
Yes,
So
sir.
what I wanted to know is if the systemic steroids which you are introducing, where exactly do you introduce it? Do you introduce it before starting antivirals, simultaneously, after some time? Where exactly do you introduce?
We generally, I think we generally started after starting the antivirals to
Why?
give a,
What's the rationale of starting steroids in this case? I mean, you're right. I'm not saying that should not be given. Why should there be a delay? Why should you be doing it after you start the antiviral?
so to give a baseline cover for the with the antiviral, and then we can give a steroid to reduce the inflammation.
Right. So what you also have in these cases is this is apart from that being a retinitis, this is also a case of very aggressive small vessel occlusive vasculitis. Right. So you are having an optic atrophy developing. So you also have peripheral occlusive vasculitis, and most of the other complications like retinal detachment partly are due to because the peripheral ischemia as well. So you want to cut down on the vasculitis part, and that you can do in two ways. One is antiviral, which is the treatment of the cause, and then simultaneously you want to cut down on the perivascular, the periphlebitis part and the vasculitis part, right?
So you
Would you
would
want to do anything else? Yeah, so Dr. Basu, please go ahead.
no, you finish your question. I thought.
Nikhil,
No, I
good.
just wanted to ask, do you want to add anything else to the treatment in such cases? In a case of acute retinal necrosis, is
We
there any
should,
role of aspirin?
maybe I'm not sure. Sir.
Athira, can you answer that question?
Ma'am, there is a role of aspirin, and firstly we start antivirals, then we give steroids, and then aspirin was also added. But ma'am, I'm not really sure the mechanism of action of aspirin here.
Any comments, sir? Dr. Basu?
Yeah, so aspirin was tried, but it does not have very high quality evidence for use. It was tried for the same reason to prevent vascular, the ischemia induced by the vascular involvement. But its utility doesn't have very high quality evidence, so we don't use it very commonly. In our practice here, we depend mainly on oral val acyclovir, okay? Because you can give it orally and it has roughly the same amount of drug availability, bioavailability as your IV drugs. So you don't have to admit. The thing is what dosage of oral valacyclovir you give. So usually if the amount of retinitis is limited to 1 quadrant, then we give only 1000 milligrams TDS. But if it is more than 1 quadrant of involvement, like many of them come with 2-3 quadrants of involvement, then we give 2000 milligram TDS, and we have to tell it very clearly to the patient because the tablet is expensive and you're giving that tablet 6 times a day. It's not an easy thing to either afford or take. So that has to be very clearly explained. So the way we start our treatment is 2000 milligram twice daily for most of the patients who come to us because they already have very advanced disease by the time they reach us. And then I take another look in 2-3 days time, see that there's a clear response. The lesions have become less bright. Look at the brightness of the retinitis lesions. So they would have become less bright. They may not have reduced in size, but the edges of the lesions would have become more defined, not fuzzy. Anything in retinal inflammation is fuzzy margins is equal to active inflammation, and well-defined margin is equal to resolving inflammation. So when you see these things, you know that the treatment is responding, and then you add your steroids. Usually methylprednisolone is not needed. You can just give oral steroids, that would suffice. But you go about it very aggressively because otherwise you may lose the eye, and keep a very close watch for retinal detachment because you might end up treating the retinitis and resolving it, but the detachment will blind the patient. And these are such fulminant detachments that they will just, it's a matter of time before you lose the eye. Okay, so we could have talked more about the drug resistance and other things, but I'll recommend that with this discussion, you go back and read up on that, and that would be a good thing to remember for future.
Thank you, Dr. Basu and Dr. Nikhil, for such important pieces of information, and I'm sure they'll benefit both of them immensely in their exams. So, Dr. Piyush, can we move ahead to the second case now? Okay, so the next case will be presented by Dr. Athira, and her mentor is Dr. Satish, and I request Dr. Athira to share her screen. Both of them are from BJ Medical College. She is a second-year resident, and Satish is associate professor at Department of Ophthalmology, BJ Medical College.
Can I start now?
Yeah, please.
Good evening, respected faculty. Myself, Dr. Adira from, I'm a third-year PG resident from BJMC Sassoon Hospital, Pune. Today, I'll be presenting a case of a 72-year-old female house worker who was apparently ordered 1 year back when she started complaining of diminution of vision in the left eye, which was gradual in onset, painless and progressive in nature. And 10 days back, she started experiencing pain, which was insidious in onset, dull aching, and along with redness. Past history, she has a history of right eye cataract surgery done 4 years back. No history of ocular trauma or ocular surgery in left eye. No history of any systemic infection or inflammatory diseases. No history of photophobia or ocular surface irritation at present. Family history was not significant. On ocular examination, facial symmetry was maintained, head posture was normal, ocular posture was normal. Extraocular movements were full, free, painless in all gazes for both eyes. On examination of right eye, her BCVA was 612. Her intraocular pressure was 18 mm Hg. Rest of the examination was normal, and she was pseudophakic in the right eye. In left eye, the vision was a hand movement close to face with PL positive and PR, the perception of rays was accurate. Her pressure was 12 mm Hg. She had conjunctival congestion. There was AC cells of grade 3 and hypopyon present in the anterior chamber of 3 mm. Iris was normal pattern and color, and iridodonosis was present. 1 second. From 10 to 3 o'clock, and it was also non-dilating pupil. Pupil was small in size, 2 mm, sluggishly reacting to light, and there was cataractous lens seen, as we can see here, with inferiorly sunken nucleus. Media was hazy. While examining the fundus, media was hazy, and details were not clear, as it was also a non-dilating pupil, so we could not visualize much. On investigations, hematological investigations were all within normal limits. On B scan of the left eye, the impression was bulky edematous heterogeneous iris with dense internal echoes in the posterior segment, possibility of infective etiology, they said. So we started the patient preoperatively on left eye, eye ointment atropine sulfate 1% BD, and eye drop prednisolone acetate 1% QID. And after 5 days of the above treatment, the hypopyon resolved completely, and the AC cells from +3 it came down to +1, as we see in the picture. Surgical management, the patient, like after the eye was quiet, the patient was posted for small incision cataract surgery with PCL implantation under local anesthesia. Since the pupil was non-dilating, intraoperatively four iris hooks were used for pupillary dilatation, as we see here. This is the IOL placement, and this is the post-op picture of that eye. Post-operatively, vision was finger counting 2 meter. The pressures were digitally normal, and conjunctiva had conjunctival congestion. Cornea was clear. Anterior chamber had +2 AC cells and AC flare of +2, and air bubble was present superiorly, as we see in the picture. Iris was brown in color with sphincter tear at 7 o'clock. Pupil was mid-dilated and sluggishly reacting to light. The IOL was in situ. While visualizing fundus, it still seemed hazy, and we could not see details post-op as well. Post-operatively, we had started patient on eye drop prednisolone acetate 1% QID, eye drop moxifloxacin 0.5% QID, and eye drop pomade 2% BD. So this is the case summary. Preoperatively, this was the case with the sunken nucleus and a hypopyon. We started on steroids in the patient. The hypopyon resolved. Then in surgical management was done, and this is the post-op picture. Thank you.
Before me, can you stop screen sharing, please?
Yes, ma'am.
Okay, so before we move further, I would just like to tell you that when you start presenting a case, you must start with the chief complaints. You cannot directly jump to history of present illness, and you don't have to make your slides, they're looking cramped up. So you can have separate slides. And you should always start with, because there's a protocol in your MS exam. You have to present your chief complaints, then history of present illness, then negative history, then family history, then personal history. So you have to follow that protocol, whether it is significant or it is not significant, but you have to follow that protocol. Okay. So with this, I would request Dr. Basu to ask her questions.
Okay, Nikhil, would you want to start? Otherwise,
Did I miss history of trauma in this patient? Was there any history of trauma?
No, sir, there was no history of trauma.
And so, pardon me, but what was the patient's age again?
It's a 72-year-old female.
72. Okay. So you're classically describing a case of hypopyon uveitis, right?
Yes, sir. Sir,
So what?
actually, the patient had come with, she was not even complaining of pain or redness. She had just come because her relatives had noticed and they had brought. So when we asked like a multiple times, then she was like, yeah, हाँ, थोड़ा दर्द होता है वैसा. So she was mostly unaware about her situation.
No, that is fine. We have to respect whatever the patient's presenting complaints are. But you're describing a case of hypopyon uveitis, I said, right? Your case had hypopyon uveitis. Hello?
Yes, sir. Yes, sir.
Yeah, so would you want to tell us about the differentials of hypopyon uveitis and how you reach the diagnosis of picoantigenic uveitis in this case?
Um, yes, sir. Sir,
In other words, we have picked up a pattern here. So would you want to walk us through what's the thinking process behind the reaching the diagnosis? Because as you said, your B scan said that this patient possibly has a possibility of infective pathology.
yes.
So how did you veer towards diagnosis of phacoantigenic? You're not incorrect, but want to
Yes,
know
sir.
about how you thought about it.
Yes, sir. So initially, when the patient presented with hypopyon, we were thinking of infective etiology. But then, sir, like if it was an endophthalmitis with a hypopyon, it would have been more severe. The complaints would be more about pain, and there would be chemosis, edema, and sir, the eye wouldn't be as quiet as it seemed in this patient. So, sir,
You
and the
expect those
complaints would
findings
be
in a case
much
of,
more.
let's say, fungal endophthalmitis?
Yes, sir.
No, would your patient have
No,
chemosis?
sir. For sterile hypopyon, no, no. Sir, and sir, since there was also a sunken, like absorbed cortex and a sunken nucleus, and since the pain and it was not the primary complaint, we thought it would be more of a phacogenic than an infective endophthalmitis. And she did not have any infective, like past history of any recent infections or admissions or any of that sort. Or and so there is also juvenile arthritis in which there is hypopyon, but then sir, the age factor, so that is not there. So in that also there is quiet eye with a hypopyon, so that wasn't there.
No,
So
juvenile, do you mean to say juvenile idiopathic arthritis? In that case,
yes,
hypopyon
a
is not very
juvenile.
common.
Sorry,
No,
sir.
in that case, yeah. In case of juvenile idiopathic arthritis, if you mean that, then the hypopyon is not such a common finding in those cases.
Yes, sir.
What are
Like
more
with
common entities? Which are more common entities where you find hypopyon uveitis? Not specifically pertaining to this case. I'm asking in general. Which are the common entities which can give you hypopyon uveitis?
Yes, sir, I mean to ask you that is there any other causes like example inflammatory or infective or must be some trauma or some other iatrogenic causes in that way?
Yes, sir. Sir, if the patient had undergone, like if it would have been, there would have been a history of trauma, sir. Like lens particles do come into the anterior chamber and it causes a severe reaction, and that can cause hypopyon, uveitis. And sir, mostly that is where we see. And in
Okay,
infective,
so let me put it the other way around to bring out a more commoner causes of hypopyon uveitis. Suppose you have a patient
yes,
who
sir.
is, let's say, 30-year-old male who comes to your
Yes, sir.
OPD with lots of pain, photophobia, and has hypopyon uveitis. Would you be thinking of some other causes in that case?
Yes, sir. In sir, the sir, HLA positive and like spondyloarthropathies, they also present with hypopyon. In Behçet's disease, also it's common.
HLA what? Which HLA?
As a B27 HLA.
So, you know, let me try to make it easier to remember. Okay. So you divide the hypopyon uveitis. First of all, you rule out any trauma or surgery. That assuming there is no history of trauma or surgery, because if those are there, you think of post-operative or post-traumatic endophthalmitis first. Okay. But assuming it's not there, you divide it into two parts: the red eye hypopyon and the white eye hypopyon. Okay. So
Yes, sir.
now, can you or Avni, one of you, tell what are the causes of red eye hypopyon? We have already discussed, but still, once again, red eye
Sir,
hypopyon.
red eye hypopyon could be in endophthalmitis and
What
in
endophthalmitis? What are the types of endophthalmitis? We have ruled out post-traumatic and post-operative, right? Already. We're not
yes,
considering trauma surgery. So what endophthalmitis is that?
sir, endogenous endophthalmitis.
Endogenous, great. So one cause is endogenous endophthalmitis, and I'll come back to it later. What is the more common cause of red eye hypopyon uveitis? You have just mentioned that.
So syphilitic.
Now, don't give. You have just mentioned it. We were talking about it just now. Which is the most common cause of hypopyon uveitis? Red eye, white eye, whatever. Absolutely the most
Sir,
common cause.
HLA B27
HLA
positive.
B27. Okay. HLA B27 type anti-uveitis. So that is the most common cause. So the two causes of, I'm not taking phacolytic uveitis here, which is a very rare cause, especially in today's day and age. And I'll come to it a little later. Let me, finish, Nikhil, with your permission. Okay.
So
The
please go
part,
ahead.
yeah, thanks. The part on hypopyon uveitis. So red eye hypopyon B27 and endogenous. Phacolytic we are keeping aside because it's a very rare cause. So the B27 uveitis will have his or her systemic symptoms, which are mostly related to the lower back. I just called it inflammatory back pain. That's the systemic part. In the eye, of course, there would be, since it's a red eye hypopyon, there would be a circumciliary congestion. Okay. Then it will be a non-granulomatous uveitis. And what is unique about the hypopyon of B27, which is not there in Behçet's uveitis? You have read this in your book. So in B27, there is fibrin in the anterior chamber. Okay. So when that fibrin gets mixed with the hypopyon, it makes it immobile. So if the patient moves the head this way, that way, the hypopyon doesn't move because of the fibrin inside. And even in the AC, you will see flecks of fibrin floating around. Okay. So that would be the classic HLA B27 associated anterior uveitis. There would be usually in these patients, there would be a significant amount of vitritis. Now, for a long time, we have been calling this as spillover inflammation into the vitreous, but probably that's not the right way to think about it. I myself have been calling it spillover. That's not the right way because these are iridocyclitis. So in an iridocyclitis, the iritis will cause the anterior segment inflammation, the AC reaction and the hypopyon or whatever. And the cyclitis will cause the posterior segment inflammation, which is why you will see variable degrees of vitritis And usually the ones with hypopion will have very significant vitritis. It's important not to mistake these for an endophthalmitis, because it's very common to mix up a hypopion uveitis with vitritis versus an endogenous endophthalmitis. So how do you make out a endogenous endophthalmitis? What are that will also have a fixed hypopion. What else will you have? Starting with the history. For example, in B27, you have a history of inflammatory back pain. In endogenous endophthalmitis, what history would you want to know?
Sir, any history of recent hospital admission for like infective causes,
Great.
like any yes, sir, any infective um,
So on one hand, you have the foci of infection. It could be a fever,
yes, sir.
lung
GI tract
infection, a
infection.
UTI, whatever.
Yes, sir. Okay.
But there is another side to hospitalization also, which is the use of IV infusion. Okay, that
Oh,
is a way
okay.
more common cause of the infection. So usually these patients have a sudden episode of bacteremia, and the bacteria go and get deposited in the eye, which is an immune privileged organ. So the immune system is not able to detect these bacteria very easily, and they can proliferate very easily. And because it's just a very episodic event, if you do their blood culture, you will usually not get anything positive on blood culture. So you would want to know a history of any IV infusion, and especially in rural settings where patients may be going to quacks and all. Quacks are very quick at giving an IV infusion for everything in the world. Okay, so those are the most common scenario of endogenous endophthalmitis. Okay, now this is with the history. What do you get in the eye apart from the hypopion? What will you see in the eye?
So there would be severe conjunctival congestion,
Yeah, it's also
chemosis,
a red
like
eye
typical red
hypopion. So
eye.
they would, yeah, it's
Yes,
also,
sir.
I told you these are the two red eye hypopions. Okay, so there will be a red eye
Yes, sir.
hypopion. What else? Starting with the lids.
So there would be lid edema
Lid edema, pain,
and
but
discharge.
usually
Yes, sir.
discharge not so much, but usually unlike post-operative or post-traumatic endoph, where the infection starts from the front and goes behind, which is why you see more of the anterior segment inflammation in post-operative or post-traumatic, right? So these are the patients who have more of lid edema, chemosis, etc. Endogenous, the infection starts at the back and comes in front, which is why lid edema may not be very obvious in a lot of patients. What else will be there in the fundus? See, even the B27 may have a significant vitritis. Okay, you may not be able to see the fundus very well. Okay, but what will be there in endogenous which you will not get in B27?
So vitritis would be there in
Both.
could be there in both. Yes, sir. Vitreous haze. Specific
This is a
to
very common clinical dilemma, and I can tell you even now I get stuck with quite a few cases. Okay, it's not easy to distinguish as I'm talking to you. Okay. So the other thing you look for is a yellow glow. However is
okay, yes, sir.
high is the amount of vitritis in B27, you will never see a yellow glow in B27. On the other hand, in any form of endophthalmitis, be it endogenous, postoperative, or post-traumatic, you'll see a yellow glow. That is usually the thing that, apart from the history, that takes you towards one or the other diagnosis. So these are the two common causes of red eye endophthalmitis. Of course, phacolytic uveitis can also cause red eye hypopion uveitis. Now, what are the causes of white eye hypopion uveitis? You just mentioned the cause.
So spondyloarthropathies.
No,
Both, that
you're
is
not
both,
listening
sir.
then. Huh?
Nice, sir.
then what is the cause of
So juvenile idiopathic arthritis.
see, Dr. Nikhil just told you that GIA does not cause hypopion. You
Hypopion
have to
is not
listen to what we are trying to tell you, right? He just told you
Yes,
it doesn't cause hypopion. So what
yes, sir.
you just mentioned yourself, the
The
diagnosis.
Behçet's disease.
Behçet's disease. So that's a common cause of white eye hypopion. Now this is a very funny thing because Behçet's causes really explosive inflammation in the eye. It is one of those rare diagnoses where you would like to start the treatment with biologics. Okay. So despite such an explosive inflammation inside the eye, sudden drop of vision and all the bad things, still you have a white eye. Okay. So apart from a white eye, what else will you see in Behçet's? I just told you some time ago. See a mobile hypopion because there's no fibrin in the Behçet. Okay, Behçet hypopion. So you keep the head tilted, the hypopion will also tilt on that side. So in Behçet, you will see a mobile hypopion. Then how will you make the diagnosis of Behçet disease? How do you make a diagnosis of Behçet disease? Yeah, that's exactly the wrong answer I was waiting to hear. Okay, so Behçet's is not diagnosed by B51. Okay, because up to 12% of normal population can have B51 positive and up to 30% of Behçet's patients can have B51 negative. So never ever, if you come to my clinic, you will never see one patient getting tested for B51. Okay, never. So the way you diagnose Behçet is by asking for history of oral and genital ulcers. That is and it has to be a painful chronic ulcer of 3-month duration. Recurrent, painful, chronic ulcer, then only oral or genital, definitely oral. Genital may or may not be present. Oral ulcer, that will give you the diagnosis of Behçet. There are many other secondary signs, the skin nodules, the pathergy test, etc. But it's a clear history of oral and genital ulcer that will give you the diagnosis of Behçet. Okay. I'm not going into the other details of Behçet. And there is one other important cause of white eye hypopion, which you should never ever forget. It's a rare cause, but it's absolutely mandatory to remember it, especially at the extremes of age, very young and very old patients. What is that? The hint is in the extremes of age. I don't think examiners give so many hints.
Sir, lymphoma.
Yeah, so a better word for that, you're correct. A better word for that?
If you were to discuss the etiologies of uveitis, you typically divide them into infective, non-infective.
Yes.
Sorry?
Masquerade syndromes. Okay. And masquerade could be anything. All right. So masquerade could be a lymphoma, a leukemia in a child, a retinoblastoma. Especially in a child, you never ever want to miss a retinoblastoma. Okay. So child coming to you with hypopion uveitis, don't think of GIA, think of masquerade. Because remember, there is an entity called retinoblastoma in older children, and you don't want to miss that. Okay. So this was about the hypopion uveitis, which I think was the most important learning from this case. All right. The other thing was the way you presented your case, and ma'am has already told you a few things. I would have definitely wanted to see in any uveitis patient, and do this in the next uveitis patient you see in the clinic, always make the anatomical, the morphological diagnosis. Don't jump to blood tests. Believe me, blood tests have very little role, okay, in a large number of uveitis patients. So make the anatomical and the morphological diagnosis. I didn't see that in the presentation. I don't know if I missed it. Okay. So that's important. The other thing is one word which was staring at you from the lens finding. What do you call that lens? What type of cataract was it? You have a name for that cataract? I think this is a make or break question in your PG.
It's a hyper mature cataract that
Better word
so,
for that. This is like ancient
Morganian.
ophthalmology. Yeah. So where was Morganian in your presentation? I think if you were presenting this in your exam and you missed saying Morganian, it would be big trouble. Okay. Everything else can be forgiven, but not this one. Okay. So these are things, I think, from my side. We are almost time.
Dr. Nikhil, would you like to say something?
Yeah, sir, as Dr. Basu pointed out, sir, we do in UVI tests, we do tend to describe our cases in terms of, anatomical descriptors, pathology descriptors, temporal descriptors, and so on. So try to, confine yourself to that system to, to lead a logical way of getting to your differentials.
So Dr. Basu has emphasized the importance of clinical examination, and I know that all the postgraduates they feel that uveitis case is a very difficult one to present in their exams. But I'm sure this webinar will help them immensely, all the postgraduates who are listening to us today, and later also they see on the YouTube. So we get a lot of reviewers for these webinars. So we are almost towards the end of the webinar, and I request Dr. Piyush Bansal to say the concluding remarks.
Before that, I mean, I missed some part of your presentation, Atira. I was there during the discussion. Very valid, very good points for me as well that I learned as well. Now, in your presentation, did you also check for the pressure? I might have missed it. Did you also check for the pressures, and did you look at the angles in this particular patient, and you do a B scan, or you had a view of the retina?
Yes, as a B scan, they suggested infective etiology. That's the only impression they gave. And the pressures were normal and angles were open. So the pressure was still edgy on Goldman appellation tonometer. So it wasn't brisk.
Yeah, the only reason I ask, and when you have these cases of anaphylactic or phacolytic uveitis, so you can have the angles that are closing up, and that can lead to pressure elevation also. So I think Soumya sir has covered pretty much everything, and even taught us about the other differentials and how we can, arrive at a more clear diagnosis. It's very important, like sir said, about having a very good clinical differential rather than depending on the investigations. And we also have Dr. Shirish Thuratsa. So Thuratsa is the president of the Maharashtra Ophthalmological Society. So, sir, if you're there, would you like to say a word of appreciation to Dr. Basu and Dr. Nikhil Beke?
Please go ahead. Frankly speaking, it was absolutely fantastic webinar. And frankly speaking, I joined this webinar as a student. I'm not as a president of Maharashtra Association. And I really remember my days of sitting in front of the external examinations. Great topic, great discussion, and got to learn many things from the well-learned Dr. Basu and Dr. Nikhil Beke sir. As of Dr. Piyush sir, Dr. Wari madam, and Dr. Smith for giving such a wonderful academic piece. And looking forward to many such experience. Thank you.
Thank you so much, Basu sir, and thank you, Nikhil. We hope to have you again with us for more interesting cases in uveitis. We had two very interesting cases last week, and this was a follow-up to that particular one. Like Madam said, that we're doing uveitis cases this month. So in the next round, please do join us and teach us some more pearls regarding.
And I would just want to congratulate both the residents for making the effort. It's not easy to sit and present. So if you didn't like me saying something, don't worry about that. Okay, I'm glad you took the effort.
Yes, sir.
Thank you, sir.
Thank you, sir. Thank you so much. So,
Thank you.
Well done, Dr. Avni and Atira. And thank you, everyone. Wish you a very good night.
Okay. Thank you.
Thank you, Basu sir and Nikhil sir.
Thank you.
Absolutely
very much.
fantastic. Yes, yes.